Okay, let's gonna start with chapter 16. We are gonna be talking about blood pressure. Okay, arterial blood pressure, special arterial blood pressure. Remember that every time when you see the BP blood pressure is referring to arterial. Also, we have pressure in the veins, but that's another history. Okay, pressure difference between the left and the right side of the heart produces systemic movement of blood. That's why the left side there is more pressure than in the right side. Remember that the right side pumps the blood just to the lung, and the left side pumps the blood to the whole body. That's why in the left side there is always more pressure. Arterial blood pressure is produced by the force of left ventricle contractions overcome the resistance of the aorta, that is the afterload. Determination of systemic blood pressure, we have the cardiac output. Right there you have the formula of the cardiac output. It's a stroke volume. A stroke volume is the amount of blood that the heart pump in one beat. Okay, so cardiac output is the stroke volume times heart rate. Okay, because cardiac output is the amount of blood that the heart pumps in 1 minute. Okay, and the diastolic volume is the preload amount of blood returning to the heart. That's the preload, the amount of blood that is in the heart, okay, before we start the systolic. Okay. Systemic vascular resistance is extremely important because it's the major contributing factor for the blood pressure. Okay, systemic vascular resistance is the radio of all the arteries, the small vessels, all of them together. Okay? Measurement of blood pressure, we have systolic, diastolic. Okay? Remember, systolic is always the high number, diastolic the lower number. Stroke volume is the primary factor influence of systolic pressure. Systemic vascular resistance, remember that is extremely important for the blood pressure. Okay, and pulse pressure is the difference between systolic and diastolic. Okay, so you have 120, okay, over 80, the difference is 40, that's the pulse pressure. Now we have this that is extremely important, is MAP. That means the mean arterial pressure. Okay, mean arterial pressure is calculated by 2 times diastole plus systole divided by 3. Okay? Typically, you determine the mean arterial blood pressure. Why? Because in the heart cycle, okay, in the heart cycle right here, okay, you divide it like this in 3, okay, and 2/3, oh no, sorry, okay, 2/3 is diastole and 1/3 is systole, okay, and all together is the mean arterial blood pressure. Okay, direct measurement of the blood pressure require intra-arterial catheter that is used just, for example, in ICU. Okay, patients that are in ICU, then you put that catheter that goes straight to the heart, and they measure the blood pressure. It's the most precise measurement of the blood pressure. Okay. Indirect measurement of the blood pressure is the one that we use every day. Is the stethoscope and the sphygmomanometer. Sphygmomanometer is the one that you put in the arm of the patients, and then you inflate the cuff. Okay, require careful technique, auscultation of Korokov sound. Remember the Korokov sound. Normally we have a laminar flow, okay? That's the normal flow of the artery, but when you occlude the artery, you make activation of the laminar flow, and then when you reopen the artery, you hear this sound, that is the Korsakoff, okay? Also, we have the White-Coat effect, is described in every book, and I don't believe so much in White-Coat effect, but it's described in the book. And for your future, when you become a nurse in your near future, if you see that patient says, I have a white coat, okay, you put the patient sitting in the sitting position, you measure the blood pressure is high, then you left the patient right there for like 10 minutes. And 10 minutes later, you measure the blood pressure again, and if the pressure is still high, then basically, uh, is how you rule out white coat effect. Okay? Now we have elderly auscultatory gap. Um, Auscultatory gap is basically a gap that everybody have in the uh, systole. Okay, that's why you have to go the systole. You have to, when you inflate the cuff, you have to feel the pulse of the patient. Once the pulse stop disappear, you have to go like 20 more up or 30 more up, because right there you have the gap, the systolic gap. Okay? Now we have short-term regulation of systemic blood pressure. Change in BP are mediated through activation of sympathetic nervous system. Of course, when you activate the sympathetic nervous system, you release the epinephrine and norepinephrine that make vasoconstriction and increase the blood pressure. Okay, and the parasympathetic nervous system is the relaxation. You have vasodilation, and you slow the heart rate and lower the blood pressure. We have a vasomotor center directly activated by various stimuli. We have the MAP, we have activation of the alpha, the beta receptor. That's why there is medication that target those receptors to for the treatment of blood pressure. Okay, the alpha and the beta receptor. Okay, beta receptor are more in the heart. Okay. That's why maybe you hear about the beta blocker. Okay, beta blocker is a medication that blocks this receptor. Chemoreceptors stimulate the medullary vasomotor center that increase CNS. CNS is sympathetic nervous system. And we have question number 1. A person jumped up quickly from the couch to answer the telephone and feel a big lightheaded. The feeling passes quickly because of what physiologic mechanism of blood pressure control? Who knows the answer? Baroreceptor, exactly. Baroreceptor. Listen, what happened? It's not because you stand up quickly, okay? It's just because you stand up, okay? Forget about the quickly, okay? You don't have to worry about it. Just because you stand up. Okay, remember, when you are in the sitting position, you have one blood pressure. When you stand up, what happens? Gravity pulls the blood down, okay, and that lowered your blood pressure. Then your sympathetic nervous system fired the baroreceptor, and the baroreceptor made the compensation, okay, because made vasoconstriction, and that increased the blood pressure, okay. And you have to know that, because that is the, if you hear sometimes orthostatic hypotension, that's the orthostatic hypotension, okay, and it's common in elderly patients and when they are dehydrated. Now we have long-term regulation of systemic blood pressure regulated by neural, hormonal, the renal, or connected to fluid volumes, increase in extracellular fluid volume, increase cardiac output, those are compensation that we have in our body, okay? One of the major compensation in our body is the kidney. Remember that in the kidney we have the macula densa, and the macula densa have the renin. And when you release renin, you activate the RAS, renin-angiotensin-aldosterone system. And that's one of the regulations for the volume and the blood pressure that we have in our body. Also, we have the ADH. ADH is secreting the pituitary glands and go straight to the kidney, okay? And it's the antidiuretic hormone that what ADH stands for, okay? Inhibit diuresis, that means that you don't go to the bathroom, you don't pee, you retain all the fluid. And right here we have the RAS, the renin-angiotensin-aldosterone system, okay? Remember, right here we have the juxtaglomerular cell, that is the macula densa, and right there we have the renin. What happened? In the kidney is always sensing the amount of fluid, so the amount of blood that is reaching the kidney. You have to know that 25% of the cardiac output go through the kidney, okay? So the amount of fluid that is reaching the kidney and the sodium, okay? Those are the two that are regulated by the kidney. Not regulated, that are sensing by the kidney, okay? So if the perfusion, that means the blood flow to the kidney, decrease, then the kidney sense that there is no volume in our body. Then if we don't have volumes, the blood pressure is gonna go down, okay? And that can produce syncope. That means pass away, okay? I mean pass out, not pass away, pass out, okay? So you activate that systems, the kidney secrete renins, the renins activate the angiotensin, then you have the angiotensin converting enzyme, you have angiotensin 2 producing the lungs, and the angiotensin 2 go to the suprarenal glands, and the suprarenal glands secrete aldosterone. Aldosterone go to the kidney, and when the aldosterone get to the kidney in the convoluted tubules, they decrease the excretion of sodium. So they may retention of sodium. If you retain sodiums, water always follows sodiums, and then you increase volume, and as a consequence, you increase the blood pressure. Okay? And that's the whole, everything that is right there. I explain. Okay. Long-term regulation, angiotensin 2, this is the same, okay. Normal function of systemic blood pressure, suprachiasmatic nucleus, that's the body internal clock, that's the circadian rhythms, and is regulated by the light, okay. That circadian rhythm is regulated by the light. That's why you have right here morning surge, nocturnal dip, because it's regulated by light, okay? Now we have hypertension. Hypertension is when the blood pressure is high, of course. And nowadays, you see 7.6 million of people dead for high blood pressure, because it's the silent killer. The problem with high blood pressure is that you don't feel anything, okay? Most of the time you don't feel anything. 95% of the time, high blood pressure is primary high blood pressure, because we have two, primary and secondary high blood pressure, okay? Definition and classification determined by the Joint National Committee and Preventions. Hypertension is a range of pressure between normal and stage 1. We are going to see. Okay, let me explain to answer this question. Okay, normal blood pressure is when the blood pressure is under 120/80. Okay, under, you have 120/80, that's pre-hypertension. Okay, the new regulation, they determine that the normal blood pressure is 120 over, less than 120/80. okay? 120 over 80 is already pre-hypertension, okay? Then you have a stage 1 that is at 140 and 90, stage 2, 160 and 100, okay? And then we have two more other hypertension, that is emergency hypertension and urgency hypertension. So I think we covered that later on the slide. Okay. Here we have a question. An adult patient have a blood pressure of 120 over 80. Which blood pressure classification should be documented on the chart? B, exactly, because due to the new regulations, you have 120 over 80. Now this is hypertension. So if you have 119 over 79, that's normal pressure, okay? Now we have hypertension is divided, I already say, in primary hypertension and secondary hypertension. Primary hypertension is because it's not produced by any other cause. Okay? It's idiopathic. It's an idiopathic disorder. Why? Because there is no cause. There is nothing that is producing that blood pressure. Okay. Have a subtype of primary hypertension. Those subtype is not only for primary, it's just for hypertension. Okay? Subtype is according to the value you have right here. Isolated systolic hypertension is when only the systolic is high, the systolic pressure is high. Isolated diastolic is when only diastolic pressure is high. And now we have risk factor. In the risk factor, we have one group that we can do anything. We can modify those factors, that is family, age, ethnicity, gender. And modifiables is the one that we can modify, the one that we can work, okay? We can work through the diet lifestyle change, okay? Like dietary factors, sedentary life, obesity, metabolic syndrome, and so on, okay? Primary hypertension risk factor, childhood and adolescence is maternal smoking, pregnancy-induced hypertension, dietary habits. Those are the risk factors in childhood. Okay? Primary hypertension is the silent killer, and sometimes we have in-organ damage. Okay, this is the one that may differ. Okay? So because in hypertension we have emergency and urgency, okay? And what is the difference? This end organ damage, okay? Emergency hypertension is when your blood pressure is over 220 over 120 and you have basically sign and symptom. That means that is the end organ damage. You have headache, problem in the vision, problem in the kidney, in the heart, any problem is 220 or 120, that's an emergency hypertension, and you have to give IV medication to the patient because you have to lower the blood pressure quick, okay, start. Emergency hypertension is when the patient have 220 over 120, but there is no end organ damage. So the patient doesn't have any sign and symptoms. In that case, you could give medication. It's gonna be really potent medication, but it's oral medication, okay? It's not gonna be IV. Primary hypertension, the treatments, the first thing that you have to do in hypertension, the first thing is always weight loss. The patient has to reduce the weight loss by 10%, okay? Then the second one is the DASH diet. Then you have exercise. Then you have alcohol. You have to stop alcoholism and stop smoking, and also decrease sodium intake. Secondary hypertension. Okay, remember, primary hypertension is idiopathic. There is no cause. There is no secondary cause. There is nothing producing the hypertension. Secondary hypertension is related to another disease like heart problem, kidney problem, okay? We have adult secondary hypertension, we have renal stenosis, pheochromocytoma. Pheochromocytoma is a tumor of the suprarenal glands, that medulla of the suprarenal glands, and they start secreting epinephrine and norepinephrine. Pregnancy, obesity, hyperaldosteronism. Remember that aldosterone, what happens, increase reabsorption of sodium, retain fluids, and produce high blood pressure. Hypertension, emergency and urgency. I already explained this. Remember that in hypertensive emergency, you have an organ damage. In urgency, there is no evidence of an organ damage. Okay. Orthostatic hypotension. Postural hypertension is the one that we already saw. A patient that is sitting, when they stand up, feel like headache, and sometimes the patient have like a syncope episode. This is really common in elderly patients when they are dehydrated, okay? Because when they are elderly, they start losing the ability of the chemo and baroreceptor that we have in our body. Those chemo and baroreceptors are in the bifurcation of the common carotid artery. Let me see for the people that are right here. Okay, can you see me in the video? Hi, I'm your professor. Okay, listen, this is the angle of the mandible. Right there, under the angle of the mandible, we have the bifurcation of the common carotid artery. Right there, we have the chemo and baroreceptor for regulation of orthostatic hypotension, okay? Right there, okay? And the other baroreceptor is in the aortic arch. Right here, we have other baroreceptor. That's why also I always want to give you, recommendation for your future life, okay? I hope you remember when you get to the hospital. Because we have receptor right here. It's extremely important when you have an elderly patient, never, ever touch the neck, okay? Because if you touch the neck, there is a procedure that is carotid massage. That means that you give carotid massage, you make alterations in the blood pressure, and then maybe you worse the condition of the patient. So be very careful touching the neck of elderly patient, okay? And especially if those patients have problem with hypertension. Okay, let's keep going. Orthostatic hypotension, again, excessive increase in heart rate, also can produce orthostatic hypotension. Maybe result of problem with baroreceptor and vasomotor and baroreceptor. Are the effect of drug therapy, especially alpha blocker. Okay, when you have when you give alpha blocker to the patient, you have to be very careful, because one of the side effects is orthostatic hypotension, stiffness, volume depletion, secondary disease process, vasovagal reactions, and cardiac arrhythmias. The treatment is review the medication, slow positional change, avoid hot environments, and most of the time you have to give fluid to the patient, okay? Because the most common cause of orthostatic hypotension in elderly patient is dehydration. And we have question number 3. In question number 3 is an adult patient suddenly develop a blood pressure of 110 over 130, which is ischemic stroke. Which terms will the nurse use to describe this situation? What is the situation right here? A or B? We already rule out primary, we already rule out orthostatic, and only we have A or B. No organ failure. Emily, why there is no organ failure? Ischemic stroke Ischemic stroke is an end organ damage, is organ failure, is an stroke, okay? It's an infarction of your brain. So that is an emergency, okay? The answer right here is hypertensive emergency, okay? So end organ damage is if the patient have myocardial infarction, if the patient have ischemic stroke, if the patient have renal problem, if the patient have headache, that is the most common sign and symptom. If the patient have headache, that's an emergency. Okay, because the patient have headache, most probably have increased intracranial pressure. And if you do a fundoscopy in that patient, is gonna have papilledema. Papilledema is a sign and symptom of increased intracranial pressure. That's an emergency. Okay, so always be the other way that you could know if the patient have emergency or urgency is if the patient have sign and symptom, okay? So what's an example of urgency? Urgency, the patient have this. I'm gonna put the sample. An adult patient suddenly develop a blood pressure of 210 over 130. Vital signs are normal, everything is normal, a physical exam is normal. Which term will the nurse use to describe this situation? Urgency. There is no sign and symptom, and that's extremely common. Okay, you're gonna see later when you get to the hospital, you are gonna see a lot of people walking normally on the street, go to the hospital, non-hospital, medical office. The patient go to the medical office and the blood pressure is 240 or 140. Do you feel anything? No. Are you hypertensive? Yes. Are you taking the medication? No. Bingo. Got it. Go to the emergency room, please. You see, that's the difference, okay? Now, right here, the rest of this slide is a clinical case. That clinical case is for all of you to study. You don't have to do any report. It's just for you to study, okay? Don't focus too much in those formula right there. Those formula are extremely complicated. You don't have to know those formula, okay? But that is for you to have an idea that that exists and, you know, give you some information. Any question from this chapter? Okay, if you don't have any questions, then let's go to the next chapter. That is chapter 18. Now we have alteration in cardiac function. Now we are going to be talking about problem in the heart. Okay, heart disease, coronary heart disease. That's another name. Coronary heart disease, also called ischemic heart disease, is the same case problem in the heart characterized by insufficiency delivery of oxygenated blood. Okay, most of the time it's because the heart doesn't have the ability to cover the metabolic demands of your body. Okay, sequels of congestive heart of coronary heart disease include angina pectoris, that's chest pain, myocardial infarction, dysrhythmia is arrhythmia, heart failure, and sudden cardiac death. Etiology of coronary heart disease, known the risk factor. Always you have to know the risk factors. The patient have any risk factor. Then we have atherosclerosis causes narrowing of the arterial lumens, and that produces ischemia. And if you don't reopen that ischemia, or can produce necrosis. And if you have necrosis, is an infarction. Okay? Mechanism of coronary arteriosclerosis is lipids are transferred by apoproteins. So I'm not gonna read these, but at the end, the problem is accumulation of lipids in the blood vessel. That accumulation of lipid plus other material may obstruction of the blood vessels. Okay. Mechanism of coronary arteriosclerosis, arteriosclerotic plaque formation, You see, it's the same. Then you damage the endothelium. If you damage the endothelium, you worse the condition because you could initiate the coagulations, and that may more obstruction. Okay, and always you have to know that it's linked to the LDL. Okay, that's the bad cholesterol. LDL. Okay, HDL is the good cholesterol. Mechanism of coronary atherosclerosis. We have the macrophages. Remember that you make alteration of the endothelium, you can activate the macrophages, and then the macrophages form the foam cell. Okay, that is a cell that is filled with lipids. Vulnerable plaque may rupture. If you rupture the plaque, then what happens? That plaque start traveling until they reach one part that made the obstruction, and then you develop the ischemia, angina in that area. There's not only angina pectoris, but if you have problem in the heart, is angina pectoris, and then the myocardial infarction. Okay, you have to know these vulnerable plaque have large lipid core and thin top. Okay, that's extremely important. High shearing stress, stable plaque have more collagen and fibrins. Stable cup. Mechanism of coronary disease increase the plaque vulnerability. So this is the same. You rub the plaque, and the plaque is released. Okay. Now we have a question: which plaque is more prone to rupture? And right here, you have to remember what I said before. Okay. And the answer is this. Okay, because this is the one that is gonna rupture. Okay. Because have a lot of lipids, and the cap, the one that encloses that lipid, is thin, so it's more at risk to rupture. The physiology of ischemia. Remember that ischemia is the lack of oxygen. Okay, you don't give enough oxygen to that part of your body, and you can cover the metabolic demands. If you can cover the metabolic demands, that is going to produce pain. Okay. A factor in meeting cellular demands for oxygen, rate of coronary perfusion, myocardial workload. Coronary perfusion can be altered by large, stable atherosclerotic plaque, acute platelet aggregation, thrombosis, vasospasm. There is one type of angina. Angina is the pain in the chest. Okay, we have angina pectoris. There is one type of angina pectoris that is called pismero, and it's due to vasospasm. Okay. Acute occlusion, plaque disruptions, and thrombus formation result in unstable angina or MI. Angina could be stable or unstable angina. Okay. The main difference is that stable angina is produce pain only during exercise. Unstable angina produce pains during exercise and at rest. Okay. Myocardial ischemia may commonly be caused by coronary spasms, hypoxemia, low perfusions, coronary syndromes, chronic syndromes with a slow progression because of chronic obstruction from stable atherosclerotic plaque, stable angina pectoris, ischemic cardiomyopathy. That's why sometimes you heard that the patient go to a stress test. Okay, stress test is to rule out this. Okay, a stress test. So you put the patient in the treadmill, and the patient start walking, and if the patient have a stable angina or some obstructions, the patient is gonna feel the pain. Okay. Clinical features, management of coronary syndromes, acute coronary syndromes associated with acute change in plaque, is a life-threatening condition. Of course, it's a life-threatening condition because produce myocardial infarction. Okay, that's why you have to work fast. So any patient that walking in the emergency room with chest pain in the first 6 hours, the gold standard test to rule out myocardial infarction is EKG, 12-lead EKG. Okay. Angina pectoris is the chest pains. The chest pains have like quality. What is the quality? That's why when you are interviewing the patient, you ask, what is the quality, how you describe the pain, and according to the descriptions, sometimes you could be more toward to infections, pericarditis, or myocardial infarction. Okay. Myocardial infarction most of the time is a squeezing. Okay, it's like have an elephant on top of my chest. That's the myocardial infarction. Okay, and can produce referred pain. Angina pectoris, we have three patterns of angina pectoris: stable, unstable, and the let me see, we have the other one, and the prismeta. Okay. The stable angina pectoris is when the patient have chest pain during exercise. Okay, most of the time is released by rest or nitroglycerin. Okay, that's the treatment, rest and nitroglycerin. Unstable angina pectoris is the patient that is not described right here, but unstable angina pectoris is the patient that have pain at rest. Okay, pain at rest and is not released by nitroglycerin. Okay, if the pain is not released by nitroglycerin, most of the time is an MI. And the prismeta is due to a vasospasm. Okay, it's due to a vasospasm, and in those patients you have to give calcium channel blocker. That is right here. That's the medication that we use for that type of condition. Now we have acute coronary syndrome, chest pain, usually more severe and lasts longer than typical angina. Then we have unstable angina, have myocardial infarction, that is a complete occlusion, and the gold standard test here. You do EKG and you drop the blood for cardiac enzyme. Those are the biomarkers. Those are the cardiac enzymes. Okay. Right here we have the two type of MI. Okay. We have one type of MI that is STEMI, I mean ST segment elevation myocardial infarction, and we have the NSTEMI. The NSTEMI is non-ST elevation myocardial infarction. Okay. That's why in the EKG, one of the main thing that you have to know is to identify myocardial infarction. Okay, remember the EKG is like this, then we have this. Okay, so this right here, this point right here, okay, is the J point. So this is the EKG, this is the baseline. Okay, this is right here, you have the baseline of the EKG. So if this is right here, that's ST segment elevation. Okay, that's how you identify ST segment elevation. Now we have acute coronary syndromes, acute occlusion, caused by range of cellular events, depends on ability and adequacy of collateral blood flow. That's why you have a myocardial infarction in a young patient, the outcome is most of the time worse that you have the same myocardial infarction in elderly patient. Why? Because with the years, elderly patient develop this collateral blood. So if you make an obstruction one part of the heart, you have the collateral blood that gives blood supply to the same area. Now we have what happens when you have a myocardial infarction. Okay, after 18 to 24 hours, area of infarction become paler than surrounding tissue. They become like white. Okay, 5 to 7 days turn yellow, and 1 to 2 weeks necrotic tissue. Okay, and by week 6, then all that necrotic tissue is removed and replaced by fibrous tissue. Okay, fibrous tissue. Okay. Okay, acute coronary syndrome, we have the diagnosis, sign and symptom. The patient is gonna have chest pain, you do the EKG, and in the EKG you have to look for ST segment elevation, okay? If you have ST segment depressions, that's ischemia event. That's ischemia, just ischemia, okay? And most of the time, all ischemia, okay? Myocardial infarction, ST segment elevation, okay? And biomarker, cardiac enzyme, because you have chest pain, the EKG doesn't show any change in the ST segment, then you have to go to the biomarker, okay, cardiac enzyme. If the cardiac enzyme are elevated, you have the STEMI, okay, non-STEMI. Elevated specific marker, severe crushing, excruciating chest pains. They could radiate to the shoulder, to the jaw, to the back, okay, accompanied by nausea, vomiting, diaphoresis. Diaphoresis is sweating, excessive sweating. Lasting more than 50 minutes and is not released by nitroglycerins, okay? Asymptomatic MI, silent MI could happen and is common in diabetic patients, okay? The elderly patient with diabetes nephropathy, and in the EKG, you are gonna look for ST segment elevation, okay? Inversion T wave, most of the time is all myocardial infarction, okay? It's an ischemia, just ischemia, okay? Acute coronary syndrome, serum marker change, myoglobin, troponin. The one that always you measure is the troponin and the CKMB, okay? So those are the one that you mentioned, CKMB and troponin I and T, okay? Myocardial infarction lead to drop in cardiac output, trigger compensatory response, include sympathetic activations. Okay, when you activate the sympathetic system, you are going to increase the heart rate, contractility, and as a consequence, you increase the blood pressure. Overall, prognosis for myocardial infarction difficult to determine because of particular. It's really hard, but when you patient with the patient walk to the emergency room with chest pain, you do the EKG, cardiac enzymes, is positive for MI, the patient go to the cath lab. Okay, in the cath lab is where you do the catheterization. Okay, in the catheterization, then you know what are the arteries that have obstruct. Okay, in what artery you have obstructions, and then you also in the MI, you know what part of the heart is the infarction. Okay, and in you know the part of the heart that is infarcted, also you know what is the most common artery that is obstructed, okay? Because according to the anatomy, you know what is the artery that gives blood supply to that area, okay? The treatment is okay. The treatment is decreasing myocardial oxygen demand, sympathetic antagonist, rest, heart rate control, pain relief. After load reduction, increased myocardial oxygen supply, thrombolysis, angioplastic monitoring and management complications. Okay, those are general. You don't have to know the treatment for MI, but if some of you want to know the treatment, one way to remember the treatment of MI is MONA, MONA, batch. Okay. Those are all the medication that you give to a patient with myocardial infarction. Okay. It's morphine, oxygen, nitrate, aspirin, beta blocker, ACE inhibitor, heparin, statin, and if the patient go to the cardiac lab and you do the catheterization, clopidogrel. Okay, those are all the medication that we use for myocardial infarction. Okay, the first medication is aspirin. Always, always. Okay, that's the first medication in a patient with MI. Aspirin, P25. Okay, then you give oxygen, nitrate. Okay, morphine you give to the patient if the patient have pain. Okay, but you have to be very careful because morphine increase mortality in the patient. Okay, let's keep going. Those are the main characteristic of treatment for MI. Okay, another main characteristic is the beta blocker. Beta blocker are extremely important. Okay, but the indication for the beta blocker is that the patient has to go home with beta blocker. So it's not the first medication, but you have to give the beta blocker at one point during the hospitalization so that the patient go home with a beta blocker. But it's extremely important. Now we have one question. Question number 2. Reperfusion therapy is indicated for the patient with. What's the answer? B, exactly. According to your book, okay, according to your book, reperfusion therapy, because reperfusion therapy is the cath lab, okay? So reperfusion therapy patient with this. But you have patient with unstable angina and elevated serum marker, those patients also go to the cath lab, okay? So this question is not the best question, okay? You have to know because the most common myocardial infarction is chest pain, ST7 elevation. Okay, chest pain, ST7 elevation. Okay, STEMI. When you get to the hospital, you're gonna hear, is this an STEMI, non-STEMI? Because that's unfortunately that's common in emergency room. Okay, you are in an emergency room, you are gonna hear there is a rescue coming with an STEMI. Now we have sudden cardiac arrest, is also called sudden cardiac death, unexpected death from cardiac cause within 1 hour. Okay, that's the main characteristic. Okay, it has to be within 1 hour. The patient feels the chest pain, and the first hours the patient is dead. Okay, usually of an external defibrillation, CPR have increased survival. Okay, but you have to be very careful. I think you have to I mean, what is this? Discussion board this week, and you have to talk about the CPR. You have to be very careful with the CPR. Okay, CPR is only given to patients that are pulseless, that you don't feel the pulse. Okay, if you don't feel the pulse, you start CPR. Okay, so doesn't matter that the patient have a syncope, the patient is passed out, doesn't matter. Okay, that the patient is unconscious. The first thing that you do when you see a patient on the floor, that most probably is unconscious is to check the pulse. There is pulse, no CPR. No pulse, CPR. You initiate CPR and call for help. Okay, that's the first thing. Call for help. What is the help? This. Bring the automatic defibrillator. Okay. Now we have chronic ischemic cardiomyopathy. Is heart failure developed insidiously? Typically have a history of angina or MI. Let me see. We have right here. Endocardium valvular structure may be damaged by inflammation of scarring, calcification, congenital malformation. All that can produce cardiomyopathy. Okay? In endocardium vascular disease, we have stenosis. If you have stenosis, that means that the valve can open properly, and that produce murmur and damage to the heart. Okay? Regurgitation is that the valve doesn't close. Okay, and then you have insufficiency or regurgitation, so the blood is gonna go back to the heart. Okay. We have one of the valvular problem is mitral stenosis. Mitral stenosis is the blood flow from the left atrium to the left ventricle. If you have a stenosis, so the blood remain in the atrium, doesn't go to the ventricle, and that start producing problem. Okay. Mitral regurgitation, that means that the valve doesn't close and the blood that should be in the ventricle go back to the atriums. Okay, and also that produce problem and murmur. Okay? Because that's a murmur. Okay, mitral regurgitation is a type of murmur. Okay, mitral valve prolapse, that means that they in the mitral valve, the lips of the mitral valve for some reason are like too big and then produce the prolapse. They go to the atrium, okay, and that produce the prolapse. It's the click. Okay, that's the uh, typical sounds. Okay, the mixed systolic click. Okay, that condition most of the time is asymptomatic and is more common in women. Okay. Aortic stenosis. Aortic stenosis is a really bad condition. That means that the aortic valve can open. It can open properly. It could do because of calcification. When you have calcification on the aorta, that's common in elderly patients. In young people, it's extremely weird that you see calcification. Okay. And the aortic stenosis also produce heart murmur, and it's the crescendo decrescendo. Okay, that's the characteristic crescendo decrescendo. It's like this. Okay, that's the sound, and it's in systole. Okay, during systole, remember that we have S1 right here, and and right here we have S2. So between S1 and S2, that's the systole. So the heart is gonna this sound, okay? That's the crescendo, the crescendo. Aortic regurgitation. Aortic regurgitation is incompetent aortic valve, and that means that the aorta remain open, so the blood that should be systemic go back to the heart, okay? And that murmur is in diastolic, diastolic. Okay? Now, with disease of the endocardium, we have rheumatoid heart disease. Rheumatoid heart disease is acute inflammatory disease that follow streptococcal, okay, infection with group B, okay, and is characterized by fever, sore throat, joint inflammation, syndrome, chorea, that's involuntary movement of the limbs, and murmur, okay? Because also produce carditis. The carditis is a murmur. So you have a patient, could be young patients after an infection with this bacteria that could be a strep throat, or sometimes due to impetigo that was not well treated, and the patient now is having fever, joint pain, and murmur, rheumatoid heart disease. Okay. Also, we have infective endocarditis. Infective endocarditis is an infection of the endocardium. Endocardium is one of the layers that is covering the heart. Okay? Could be due to a streptococcus of Staphylococcus. The Staphylococcus, I mean, the Streptococcus, the one that produces endocarditis, is called sanguineo. Okay? Streptococcus sanguineo. Acute infective endocarditis, prognosis poor, intravenous drug user also are susceptible to endocarditis, infective endocarditis, okay, to the right side of the heart. Myocarditis is an inflammation of the muscle part of the heart, that is the myocyte of the heart. Okay, characterized by necrosis and generation of myocyte, clinical course acute and stormy, uh, with recovery or death. Okay, if it's too complicated, could cause the death of the patient. Okay. Myocarditis is characterized by inflammation, leukocyte infiltration, necrosis of the cardiac muscle cell. Causes include microbial agents, immunomediated disease, physical agents. Viral etiology is the most common one. Okay, that's extremely important. The most common one pathogen for myocarditis is viral infection. After viral infection, you could develop myocarditis. Okay. Cardiomyopathy classified by cause of function impaired, primary or secondary. And the functional classification is dilated, hypertrophy, and restricted. Those are the cardiomyopathy. Okay? Dilated cardiomyopathy is characterized by the heart is like a balloon. Everything is dilated. Okay, all the chamber are dilated. That's dilated cardiomyopathy. Okay, could be due to alcoholism. Alcoholism produce damage in the myocyte and can produce dilated cardiomyopathy. Pregnancy could produce cardiomyopathy, and some post-viral myocarditis, genetic disease. Okay, hypertrophic cardiomyopathy is thickening of the in the middle of the heart. That is called the septum. Okay, thickening of the septum of the heart. Okay. Those patients, you have to be very careful because this condition can produce sudden cardiac death. Okay? In young athlete patients, okay? Young people that are practicing sport. Okay, so if you see a young people, really young people that is playing any game, football, running, so it's practicing sport, I have a sudden cardiac death. Most of the time is due to this hypertrophic cardiomyopathy. Okay? The treatment for hypertrophic cardiomyopathy, beta blocker. Okay. Now we have restricted cardiomyopathy. Restricted cardiomyopathy, most of the time is due to this amyloidosis. Amyloidosis is a defect protein in our body that accumulate in the heart and produce the restricted cardiomyopathy. Also could be due to radiation therapy and other conditions. Okay. Typical sequels or other disorders such as pericardial disease, we have systemic infection, trauma, metabolic derangement, and neoplasia. All those can produce pericardial disease, pericarditis. Pericardial effusions, that means accumulation of fluid in the pericardial sac. Okay? Composition is serous, sanguineous, purulence, blood, anything that gets trapped right there in the pericardial sac produces pericardial effusion. One special characteristic of pericardial effusion or pericarditis, any pericarditis, is that it's going to produce diffuse ST segment elevation. So if you see an EKG that have ST segment elevation in the 12th lead, that's not a myocardial infarction, okay? That's a pericarditis. Cardiac tamponade is a type of pericardial effusion, but it's an acute condition, okay? Cardiac tamponades is accumulation, really fast accumulation of fluid in the pericardial sac, and that don't allow the span of the heart, and then produce the very short tria. This Beck tria. The Beck tria is hypotension, distends neck vein, and muffled heart sound. Okay, that's the Beck tria. Treatment: pericardiocentesis. Pericardiocentesis in the emergency room. Okay, what you have to do when you have a patient with that condition, you can see me. Okay, this is the left side. First, second intercostal space, you put a needle right there. Okay, mid-clavicular line, you put a needle right there, and you release the blood that is accumulating in that part. Pericarditis is acute of chronic inflammation of the pericardium, chronic pericarditis. Okay. Acute pericarditis, most cases idiopathic or presumed vital, same like myocarditis. Uncomplicated from resolve spontaneously, typically present as a chest pain, fever, leukocytosis, okay, and friction rot. This is a special for pericarditis, friction rot, okay, and diffuse ST segment elevation. Chronic pericarditis, we have two principal forms, adhesions and constrictive pericarditis. Those are the two main forms. Congenital heart disease. Now we have congenital heart disease. Congenital heart disease are divided into cyanotic, early cyanosis and late cyanosis. Okay, we are gonna see what is that right now. Embryological developments, heart defect commonly associated with this anomaly. You see, development of atrial septum, development of the ventricular septum, division of the main outflow truncus arteriosus. We're gonna see all those defects right here. Etiology of incidence of congenital heart disease may be attributed to maternal rubella. Rubella can produce problem in the heart. Okay. Let me see. The physiology of congenital heart disease resolve into primary pathology. Shunts is that you have communication, okay, between one ventricle and the other ventricle, or one atrium to another atrium. Okay, right to left, cyanotic; left to right, cyanotic means that the baby is like blue. Okay. Normally, newborn babies are pink. That's the normal color of the newborn baby, pink. Okay. Okay, now we have cyanotic congenital heart disease. Cyanotic congenital heart disease. We have atrial septal defects, ventricular septal defects, patent ductus arteriosus, partition of the aorta, and pulmonary and aortic stenosis or atresia. Those are late cyanosis. Those are called acyanotic or late cyanosis. That means that they are not cyanotic at birth. Okay, at birth they are normal. Atrial septal defects. Remember that atrial septal defect means there is a communication between the atriums. Okay, so that's the main solid right there. And most of the time is due to the foramen ovale. Remember that the foramen ovale is a window ovale, is a communication that during the embryological process we have that normal communication. Okay, then later, before you give birth to the baby, that close and form the foramen ovale. But sometimes you have some defect and they remain open. Ventricular septal defect is the same, it's communication between both ventricles and that is going to produce a shunt from left to right. Okay? Later, if you don't treat the patient, could produce Eisenman syndrome, and it's the reversion of that communication. So they start left to right and then go right to left, because produce hypertrophy on the right side, and the communication go back. Okay. Patent ductus arteriosus is the truncus arteriosus. Normally, it's a communication between the two greater vessels that normally in the embryological period that is open because we need that communication. Right, exactly when the baby is born, you see that the baby cry for the first time. Right there take place a physiological process that the air get inside the lungs for the first time. When the air get inside the lung for the first time, you use some substance, and that substance close that ductus, okay? And it's called the ductus arteriosus. If that ductus remain open, then it's called the patent ductus arteriosus. That patent ductus arteriosus also produce a murmur, okay? That is machinery murmur. It's called like that because it's a murmur that you feel in the whole cardiac cycle, okay? Whole systole and whole diastole. Rotation of the aorta is narrowing of the aorta, and when you have narrowing of the aorta, one of the main clinical manifestations is that you have hypertension in the upper extremity and hypotension in the lower extremity. Okay, that's one of the main characteristics of that condition. Okay? And that condition is common in genetic patient in this genetic disease that is called XY. I don't remember, I mean X0. It's a female that instead of have 2X, have X0. Turner syndrome. Pulmonary stenosis or atresia, okay? That means that the pulmonary valve doesn't open properly, stay like closed. Okay? Now we have aortic stenosis or atresia is the same like pulmonary but in the aortic artery. Okay? They produce like close and that may also murmurs. Okay. Now we have remember those are the cyanotic or late cyanosis, the baby born normally pink and later they become cyanotic like purple. Now we have the cyanotic, early cyanosis. Those are babies that are born with cyanosis, okay? They are born purple, okay? We have all the T's, okay? That's the main difference. You see a condition with T, that's early cyanosis, okay? After Charlie of Fallot, transposition of the great artery, truncus arteriosus, and tricuspid atresia. Trachea of Fallot is one of the most common and have four defects. That's why it's called the trachea of Fallot. And the fourth defect is ventricular sector defect, aortic positionings, pulmonary stenosis, and right ventricular hypertrophy. Okay? Most of the time, all these conditions that you see right here, all these conditions, in order that the patient survive, they need the patent ductus arteriosus. They need a communication, okay? And most of the time, it's the patent ductus arteriosus. So in those patients, you give medication to remain open the patent ductus arteriosus, okay? Like prostaglandin, you give prostaglandin to remain that open. Hello, hello. Can you hear me? Okay, I have some technical difficulty, but we are right here. We are almost uh, done with the chat. Okay, we have question number 3. Which of the following is a cyanotic congenital defect? Okay, it's extremely easy. Okay, exactly. Y is the only one that starts with T. Okay, T. Let me put it right here. Okay, T. All the cyanotic conditions start with T. Trachea of Fallot, transposition of the great vesicle. What is the other? I don't remember the truncus arteriosus. I don't know. There is like 4 or 5. Transposition of the great arteries. That means tricuspid atresia. Thank you. Yeah, transposition of the great arteries. That means that the aorta is in the pulmonary and the pulmonary is in the aorta. Okay, that condition is a really bad condition, and if you don't have the patent ductus arteriosus, the patient is going to die, okay, for sure. Okay, the treatment basically for all those conditions is surgery. Okay, most of the time you have to do surgery. Truncus arteriosus, failure of the pulmonary artery and the aorta to separate. So that means that it's just a one big artery, okay? Again, this condition is extremely weird, and when that happens, it's really bad because most of the time the patient is going to die, okay? So that's why you have to reopen the ductus arteriosus uh, to facilitate some communication in the arteries, okay? Tricuspid atresia is usually associated with development of the right ventricle and the atrial septal defect. Okay, and again, also you have to patent ductus arteriosus is required for the oxygenation in the baby. Okay, so we finish right here with the chapter. Any question from this chapter? Or any question from the whole lecture today?